Hi, my name is Halden Scott. I'm an associate professor of pediatrics and emergency medicine and a pediatric emergency physician in Denver, Colorado. As you can see, I practice within a large metro center, but patients come to us from large rural swaths of land across many miles from settings with few staff or resources. So a lot of our talk today will focus on how diagnosis of sepsis depends on context, and the tools that we select to optimize diagnosis depend on the setting in which they're intended to be used. I have no financial disclosures. Our objectives for today are to describe the patient, clinical, and laboratory features that are best for early recognition of pediatric sepsis. We will understand the components of the recognition bundle. We will consider how to customize a diagnostic approach to the resources and patients in a specific setting, and we will develop approaches to evaluate emerging diagnostic tools. Diagnosing sepsis isn't solved yet. Articles are going to continue to come out, and I want everyone to leave this talk armed with ways to evaluate whether or not to adopt a tool recommended in a publication into their setting. Pediatric sepsis on a daily basis is prevalent in 8% of children in pediatric ICUs around the world. And its mortality and morbidity is staggering. There's a 19 to 31% case fatality rate for children with sepsis. And even among survivors, 35% had not returned to their baseline quality of life 1 year after their sepsis episode, and 19% had a new or progressive medical condition after discharge from the hospital after surviving sepsis. There are many challenges in clinical care and diagnosis of sepsis. Fundamentally, sepsis is heterogeneous. It can start in any organ in the body, occur in healthy or medically complex children, and the organism will depend on local epidemiology. It can look like routine illness until a child becomes critically ill, and yet there's a need to treat quickly before the final diagnosis is confirmed. There have been multiple and changing definitions for sepsis. Treatment bundles and metrics have changed, and all of this reflects some scientific uncertainty. So when confronted with the needle in the haystack conundrum of diagnosing pediatric sepsis, we have to remember that some of this comes from the fact that while sepsis syndrome is a useful concept for first hours diagnosis and treatment, it's not truly a single biologic entity. So what is sepsis? That's sort of the crux of the issue. Some of the definitions that are still the definitions of record for pediatric sepsis depend on this SIRS criteria, a sort of stepwise progression in illness from sepsis to severe sepsis that depends on vital sign changes in temperature, heart rate, respiratory rate, and white blood cell count. However, these were published in 2005, and in general, consensus is moving away from some of these SIRS-based criteria. This is an example of a study that I did, and there have been many others like this. We looked at medical ED visits in 1 year to one of our emergency departments and found that nearly a sixth of these visits met SIRS criteria. So there were probably lots of false positives in this group. And at the same time, if we wanted to find the most critically ill children who needed a vasopressor or intubation in the ED, well, SIRS only found 20% of them. So it was the exact opposite of what you would want in a screening test. It was low sensitivity with a high rate of false positives. And I am not the only one who thought this. When adult sepsis was redefined to sepsis 3.0, life-threatening organ dysfunction caused by a dysregulated host response to infection, there were calls in the pediatric community to follow similar approaches to definition with a focus on organ dysfunction and a movement away from SIRS criteria. And these are examples of some of the schemes that have been proposed to adapt adult sepsis 3.0 definitions to children. But you may be asking, what is organ dysfunction and why should I care? In the cardiovascular system, it's hypotension, elevated lactate vasopressor use. Respiratory system is new positive pressure ventilation. The neurologic organ dysfunction is severely altered mental status. In the renal system, it's acute kidney injury manifested by changes in creatinine. The hepatic system, it's elevated transaminases, or in some schema, elevated bilirubin. And hematologic dysfunction is usually defined by parameters of disseminated intravascular coagulation, or DIC, or low platelets. However, you'll notice some asterisks, and I wrote that precise cut points may vary and are subject to change. Along the bottom of this slide, I've included several references for authors who published age-based cut points for each of these criteria in each of these schema by which you may identify organ dysfunction. However, because there's not consensus, there's not a single unifying pediatric sepsis definition that everyone agrees on currently, it's reasonable to use any of these schema, or if there are other schema that exist in your hospital system already, that is fine to use to identify organ dysfunction. For example, in our hospital, there's an acute kidney injury protocol and program that has developed cut points for creatinine based on the KDIGO system, which is not identical to the sepsis schema, but that's a reasonable approach to identifying kidney injury until there is a unifying sepsis cut point that everyone around the world agrees on. Any of these are reasonable. The second part of my question was, why should you care about organ dysfunction? These are examples of some of the many studies that have shown that even a single organ system that is dysfunctional is associated with worse outcome. In addition, each of these organ systems has implications for how we would treat a patient. In AKI, we may dose antibiotics differently. In DIC, we may plan for procedures or even delay them based on the presence of DIC. So they're important to know about. Here's another reason that's very compelling to me as someone who works outside of the ICU. So anyone working in an outpatient clinic or emergency department or general ward setting, one of our jobs is identifying, is this patient stable to stay and be treated where they are or even go home, or do they need to escalate to a higher level of care, to an intensive care kind of setting? And organ dysfunction can help us to know that. This study looked at the number of organ systems that were dysfunctional at the time of ICU admission. Each line represents patients who had a different number of systems dysfunctional, and the y-axis represents their probability of survival. Not surprisingly, the patients with the most organ systems dysfunctional had the worst survival. While this is a somewhat obvious association, it brings a question to those of us in the pre-ICU setting. Do we know how many systems are dysfunctional for our patients? When a patient has suspected infection, are we thinking about this and knowing whether we've even tested for all of these organ dysfunctions and using it to decide the disposition and treatment plans for our patients? To me, this argues that we should be aiming to get our patients into intensive care before they continue to accumulate new additional organ systems that are dysfunctional. So what are the implications of an infection plus organ dysfunction based definition? It means that we start treatment in a patient who has organ dysfunction with suspicion of infection. We do not require microbiologic confirmation to define sepsis. We consider de-escalation if we later find out the clinical picture and labs do not support infection. And while 3 of these organ systems can be diagnosed clinically, some of them do require lab tests to diagnose. While obtaining lab tests may not be available in all settings and thus can't be checked, in settings where they are available, when we're starting to worry about sepsis, when we think someone has more than just the average run-of-the-mill infection, it's time to get those labs when they're available to us. So here's the learning point. Sepsis is organ dysfunction in the setting of suspected infection. And the clinical implication is that we should check the full set of organ dysfunction laboratories when we're suspicious for a severe infection in a child who's looking more unwell than average. What are the clinical features that can aid us in sepsis recognition? I'm presenting to you findings from a systematic review and meta-analysis that was conducted by the Paediatric Sepsis Definition Task Force. This is a group that I am part of that is preparing to try to come up with unifying criteria for defining and identifying pediatric sepsis. And in preparation for this, the systematic review was conducted, looking at studies that had looked at risk factors in children with sepsis for mortality and other severe outcomes. Although global databases were widely surveyed and studies from around the world were included, the numbers of patients that ended up in the included studies were largely from high and upper middle income countries and were largely ICU patients. So these findings are really important and useful, but consider your own setting in deciding how much they apply to you. In looking at variables that were associated with the outcome of sepsis, the most predictive clinical variable was a decreased level of consciousness. And I've highlighted in yellow the column with the pooled estimated risk ratio. So there was a strong association there. Looking at variables associated with the outcome of mortality, I've also highlighted the estimated risk ratio column. You can see that some of these were demographic, malnutrition, and chronic conditions. Many were associated with cardiovascular dysfunction, hypotension, and the need for vasoactive agents. Mechanical ventilation was a very strong predictor of mortality, and changes in mental status were also strong predictors. Looking at laboratory predictors, creatinine had a high risk ratio for association with the outcome of mortality. And platelets did as well. This is an inverse ratio because lower platelets was associated with higher mortality, as did ALT. This is similar to findings of another study. This looked at different types of organ dysfunction and their association with mortality. And you can see that respiratory, neurologic, and hematologic dysfunction had the highest associations with mortality. So the learning point here is some of the clinical signs most associated with sepsis and death are altered mental status, hypotension, and the need for ventilatory support. While ideally we're diagnosing sepsis before these findings occur, it's important to design systems to activate the maximal resources when children have these clinical findings. Now let's talk about the recognition bundle. Care bundle is a set of 3 to 5 informed practices that, when performed collectively and reliably, improve the quality of care. And in the American College of Critical Care Medicine Clinical Practice Parameters, published in 2017, the recognition bundle for pediatric sepsis was first described. The elements of this bundle are implementing a systematic screen of all patients for septic shock, and when a patient screens positive, having a clinician assessment at the bedside within 15 minutes for patients who screen positive. Many people call this the huddle, when all the clinicians, clinical personnel get together and decide whether a patient has sepsis. And if they do, moving rapidly to the resuscitation bundle. So what would this screening tool look like that we're using to call clinicians to a huddle? The ideal one would predict severe sepsis and shock and mortality, work in all settings, be better than us humans without impairing our judgment, not malfunction or crash like lab tests or computers are prone to do, be easy to implement and 100% sensitive and 100% specific. As you've guessed, a perfect tool does not exist. We all need to consider the trade-offs in which elements of a tool we value most in our settings. These come back to sensitivity, specificity, and what is the cost of a true positive or a false positive in your setting? What treatments do you implement based on the outcome of a positive or negative test? If you're putting someone in an ICU or sending them home, there's big consequences to a false positive or a false negative in that setting. When we look at studies that have been performed on pediatric sepsis diagnostic tools, they're difficult to compare because everyone uses a different gold standard outcome. Many studies have used the patient was treated on our pathway, essentially testing did the tool perform the same as doctors did. And some use chart-reviewed organ dysfunction, septic shock, and mortality, more robust, firm endpoints. So here's an example of the scenarios to think through. If I'm working in an emergency department and I'm making a decision whether to draw labs or not, that is costly but not harmful to the patient. So I might prioritize sensitivity in that scenario. Whereas when I'm giving antibiotics, there's more of a downside to that, and the positive predictive value of the tool will come into play. I want fewer false positives at this stage. Before I send someone home, my tool better be sensitive. We're not going to miss a fatal diagnosis. Before I send them to the ICU and use all those resources, it better be specific. So at each point in this pathway, I may need to use an assortment of tools. Where I work, as I said, in Denver, we're in a city, but patients are coming to me from very far away, and they may be coming on a helicopter or traveling 12 hours. So there is a big cost financially and in terms of the resources deployed and the social cost to a family of traveling that distance. We really need specificity and accuracy even more before we move a child that distance. What about in the inpatient setting? Maybe if you're deciding whether to call an attending or consultant at home, you prioritize sensitivity. Yeah, there's a cost to the attending who doesn't want to be called at home, but the cost to the patient is low. There's not harm in that system. When we start to give antibiotics again, positive predictive value, and sending someone to an ICU, specificity starts to matter more. What are the tools that exist? There's many tools that have been published talking about just their test characteristics in a vacuum. There are fewer that we have published studies of their actual implementation. Some of the ones that have been implemented, these are two examples of definition-based tools. They took those consensus conference STRS-based definitions and put them live into their electronic health record and tested how they worked in clinical use. Of note, both hospitals that did this have kept these tools in use. There's also expert opinion-based tools. These were the American Academy of Paediatrics Septic Shock Collaborative designed a set of screening tools designed to predict sepsis before it happened based on things like capillary refill time. And this was implemented live into an electronic health record as well. And again, this institution is still using this tool. So I've summarized in this chart many of the tools that have been described in live prospective clinical use. I even described in Colorado, we did a study of how our clinicians were doing without the use of any systematic tool. And you can see that based on location, the sensitivity and specificity varied. For the most part, the tools that were more sensitive had lower positive predictive value, lower specificity, but that wasn't always true. Some tools just seem to perform better. So this is a good reference if you're working in a setting similar to a US emergency department of tools that might be right for you. However, what's interesting is all of these institutions have used different tools, but they've paired them with a standardized process. So they may be different from each other, but everyone in the system uses the same tool every time, and it's associated with the same treatment pathway. So while each tool is different, each has been associated with improved outcomes in sepsis. So there's some magic in doing things the same way every time. So the learning point here is no screening tool has been established as a superior tool, and you must consider your local context and priorities and standardize the systems around a tool until one emerges as superior in the literature, and we're not there yet. So in the West, we ride off into the sunset, and this is a picture of one of the kinds of places where my patients in rural locations are coming from. I want to encourage you to keep reading tools about sepsis diagnosis as they come out. Remember to consider differently ones that are describing test characteristics in a vacuum and ones in clinical use. The ones in clinical use often will have lower performance in their articles, but have actually been tested for feasibility. And please feel free to contact me with any questions. Thanks so much.